principles. The biggest things that, I mean, obviously we gotta verify our order, verify our patient, tell the patient what it is that we're doing and why we're doing it. We're doing this to maintain the patient airway and prevent you from getting infection there, Mr. Clark. So you should already have gathered all your supplies and all that stuff. So, focused respiratory assessment. There's duplicates in there. I'm not really for sure why. I didn't make this document. We can blame case of TCS on that. That's your education. Obtain their vital signs and their pulse ox, obviously. And we need to know if they're on room air or oxygen and what liter oxygen that they're on, as well as if it's via nasal cannula, face mask, like a trach tent or whatever it is that they're on. Is that what they're called, trach tents?
Sure. That's what we call them.
I like it.
Sounds wonderful.
You obtain a respiratory history. It says place the client in Fowler's position. I like to place them in a position that is comfortable for me in doing this procedure. So I would say for respiratory suctioning, probably a semi-Fowler's position. For doing a history, for doing a physical, I'm going to want you setting up, sir, and leaning forward a little bit, okay?
Can you hang their feet off the bed?
A little bit.
He looks uncomfortable.
No, he is.
Have
He's
jugular
not
vein
fit.
distension.
It's a Glasgow coma scales low. So, anyways, so make sure that when you're doing an assessment that, again, that you assess front side, and back side. You want to inspect, make sure if you can visualize the trachea, hopefully you can. Tracheostomy should be midline where the trachea is located, but inspect the trachea, make sure it's midline. Inspect the chest, make sure everything's moving symmetrically, making sure that assessing the size of it, the shape of it. If they're barrel chested, obviously that indicates like COPD. Checking, what else is there? The rate, rhythm, and the work of breathing. If they're using any accessory muscles, know that when I talk about auscultating breath sounds, make sure you guys look that up and tell me, okay, I'm listening over the trachea, I'm listening over bronchial, bronchiovesicular, and vesicular, whatever that is, because if you can do that, then you will have gotten a test question correct. Let's see, you're wanting to assess for any adventitious breath sounds such as crackles, wheezes, bronchi, and pleural friction rub. And you guys already know that whenever we're doing the checkoffs that I'm talking to you because I think that it just helps with learning and understanding. So if I ask you what bronchi would sound like, or a pleural friction rub, or what pleural friction rub might indicate, or what crackles might indicate, blah, blah, then that's not for you to pass or fail, it's for us to learn. Tactile and vocal fremitus is, so tactile fremitus is when you use your hands and you're feeling down through here, and you're having the patients, you have them talk and you're feeling for the vibration. As soon as you feel either a decreased vibration or no vibration at all on your hands, that could indicate fluid inside of the lungs. Vocal fremitus is pretty much the same thing, except you've got your stethoscope and you're listening while they're talking. If you can hear more clearly, and I think if it gets more clear, then that indicates fluid. We gotta look that one up. But, so tactile and vocal fremitus is basically just feeling and listening while they're talking. Chest excursion is whenever you've got your hands around, if I'm not mistaken, you've got your hands and hopefully if they're not like morbidly obese, then you can feel the change in this where you are kind of around their diaphragm area. You have them take a deep breath and everything moves symmetrically when they do that. And then document and report any abnormalities. You don't have to document abnormalities, but if there's something serious that you need to know. Make sure that you look, let me back up. Make sure that you're looking at the skin and mucous membranes, checking for cyanosis or any potential concerns for poor perfusion, and check their nail beds to make sure, their nails to make sure they're not clubbing. I think I got it Okay, so, Mr. Clark Kent, Mr. Kent, I'm your nurse today, I'm Robin. I'm gonna be doing, respiratory suctioning on you because you sound like crap. Do you feel like crap? You do? Okay. We're
You
gonna
can't
take care of
talk,
that.
is
Your
that-
oxygen saturation is lower than what it has been, so that probably indicates that you've got some mucus inside of your airway that needs to come out. I'm gonna listen to you. Oh, yep, some coarse crackles. We're gonna get rid of all that in just a second. Okay, so we did our assessment. I mean, you don't just at random respiratory suction, because respiratory suctioning, one, can damage the airway, even though it's a soft catheter, a flexible catheter, it can still damage the airway, and we're entering into the airway, and potentially that can increase the risk for an infection as well. So we don't just do it willy-nilly, we only do it whenever there's a cause for concern. So we've got that. Whenever you suction, you want to, oh, it's way over there.
What you mean?
I poorly planned this, Mr. Kent. Oh, it's got a temperature.
What do you mean?
A suction thing, so we put it on regular. Oh, I think it, okay, so you're gonna, excellent, good job. Keep doing it.
Keep going, Dennis.
So it's on regular, which is continuous, and you wanna make sure your suction's in between of 80 and 120 in the yellow section whenever you're suctioning. If you go too high, you can definitely cause damage to that, the inside of their lungs. Okay, so this box, it's okay. I washed my hands before I came in. So this box, I'm not gonna touch the inside. The inside is what I'm gonna fill up with sterile water, saline, whatever your facility calls for. And that was fresh, brand new, just opened it. So I didn't have to lip or any of that stuff, whatever that is. I think I've never done that in my life. I just get new ones. I am definitely, wasteful. Wasteful. Not lazy. Just, my floors were immaculate. And I'm sorry, Mr. Clark Kent, I'm using you as a table. I don't mean that tacky, but I'm out of room. If you say I'm sorry, they have no problems with that. Okay, so, all right, this is what we're gonna do. I already told you about it. You sound like crap. You're ready for it. Good. So we're gonna get to suctioning on you. Before I suction you, I'm gonna turn my oxygen all the way up. My little ball's gonna be up to the 15. I'm gonna hyper-oxygenate him. Yeah, you take a couple of big deep breaths. Let it.
You take that oxygen.
Take it. Like it. Good. Real good. You're thinking real smart right now. Real smart with that glasses. Okay, so he's taking a couple of big deep breaths. What?
Nothing?
He's taking a couple of big deep breaths. Awesome. Okay, so we're gonna get ready to suction you out. Okay, you ready? All right. Pull that back off.
I don't think she
No,
realizes.
where's my finger? I don't like these gloves, so I don't use them. Someone can if they like them. Okay. As long as I can get in there to that, that's great. Okay, these on. One hand's gonna become dirty. Okay.
Oh.
Did you just get turned on?
Oh, that was Claudia. It was a mix.
The pop got her.
The dirty and the pop. She's like, ah.
No, you're killing me.
Oh my
You need a break. You need a break.
I'm good. No,
Don't stop.
Don't stop.
Okay, so now
I don't think I'm going to post
everything
this.
always. I make everything weird. Okay, so catheter is very flexible. Sometimes you can, sometimes if they are stiff for whatever reason, you want to make sure that it's pretty flexible. As you can maybe see, the tip's been cut off, so there's a hole at the top and then there's holes on each side. So whenever you put this in there, you want to kind of rotate while you're pulling out. You put it on continuous suction, and in here I think it says do So you are the intermittent suctioning, and you intermittent suction doing this. Okay, dirty hand. Okay, so you need to lubricate the tip.
Just the tip.
You didn't help me out.
Dennis, where's your
I'm
noises?
sorry, I was just waiting for I waited for the peanut gallery to come in with the lubrication. So
Lubricating the tip. Okay, more than the tip is going in. It's all going in. Okay, you ready? Me too. So you go in. Good. Oh yeah. So you go into you hit resistance. He's coughing. So I'm twisting, suctioning, intermittently, doing this.
I'm frozen.
All right. Good. Good.
Stop.
Good. So there's
It's
lots.
not fair.
Last year or last semester when I did it,
please
I
tell me
made the
something's
most
wrong.
disgusting noises. And I'm like, that's what it sounds like. Okay, so clean out your line. Good job. How you feel? Feel okay? No, oh, you still feel like crap? Okay. Just take you a couple big deep breaths. I'll put your oxygen back on. Take you a couple big deep breaths. Your oxygen's
It's
coming
all
back
pulling
up.
up.
Looks good. Okay, we're gonna do this again because you look like crap and you sound like crap. I hear it still. We're gonna come back out. All right, you ready? No? Let's go. Good. All right, got resistance. He's coughing. So turn it and intermittently suction on the way out. I'm sorry, I'm sucking it, turning. Okay. How you feeling now? Oh, that's better. Okay, let's put some oxygen back there. Take it. Oh, your oxygen looks better than what it did. All right, let me put on a little and listen to.
81%.
Oh yeah, that's much better. Yeah, really great. And that's a whole bunch of inspiratory and expiratory. I went through the whole breath. Okay, good. He's good. He's good. You're good. So now we're done with suctioning. Document your findings, your color, consistency, amount, that kind of thing. Obviously, whenever you're sucking this up in here, you're going to be adding to whatever in the line. So if it's just a scant amount, you don't have to say 3 cc's because you really you can't do that. So just say small amount, scant amount, color, whatever, thick, thin, that kind of thing. Does this sink work?
Yes.
Okay.
Brown.
I just wanted it to go
On the
out
grounds.
somewhere, not on the ground. Okay. Excellent. And if anyone wants to utilize these things, they can.
Like if they didn't buy a lab kit.
If you want to what?
If they didn't buy a lab kit.
Yeah, those people. And here's gloves even.
Did? Yeah. Did. Yeah.
Help me, I'm poor.
Okay. Well, Mr. Kent,
You're dying.
you're gonna make it.
Oh. No CPR.
Okay, so you got a trach care. Those things get gross. They could cause for bacterial infections. We're not getting pneumonia, okay? So we want to prevent that. Want to keep your airway open. So once a shift, if that's the policy, you clean it. So and I should have had my mask on. Sorry. So for both of those, you want to actually, for both of these things, you want to wear a mask with the shield on it because nobody needs secretions in their eyes. No one. Okay, so here's some gloves. This little handy dandy feller, I like him a lot. The shiny side is the what's water resistant-ish. And then the matte side is what is absorbent. So I'm gonna put it matte side up. And I'm gonna do your trach care. He is not excited. So if you have a sterile field, and I do, right there, you can dump your stuff out on it, or you can leave your stuff inside of there, whatever you prefer to do. You can take your sterile saline or sterile water, whatever your facility states, you can pour that inside of there. And then I always did peroxide. Not for sure. Sometimes they say mix peroxide with sterile water. Sometimes they don't say peroxide. I don't know, I feel like I went rogue as a nurse a lot. So, I always did peroxide, filled it up, I have on clean gloves. Okay, so this is actually a true, trach that has to be clean. Some of the other ones have, disposable trachs. This one is actually legit trach. So these, you'll see, they lock into place, so you have to unlock it to then be able to pull it out and slide it out. You take that, drop that down inside of your peroxide, let that soak. Okay. Sterile. I'm gonna have one. Nope. That was off. Sterile. And I'm gonna take my brush and dip it down in the peroxide, and I'm gonna clean and push all that on that, and it bubbles and it's gross. Oh, that bubbles are falling back down, secretions back down inside of there. Dip it some more. Scrub it. It's so gross.
Make sure you put your mouth
Go
on it
into
and
the
blow it
other
out.
end. Go into the
Suck it
other
up.
end. So I love
You better just
peroxide.
get ones I throw away and replace. I'm
Yeah,
doing that.
right. Well, and not all of them have it though. There's some that are metal.
I've never taken care of one of those. I think I've only had one patient that had one that I had clean. Other than that, it was all disposable ones.
Good. Hopefully insurance is covering all that. Okay, so I think I got him nice and clean. I got all the funk out. So I'm gonna drop it down into the sterile water, or whatever my facility states. And I'm gonna take these little guys while he's sitting in there cleaning off. You can put it in the peroxide, you can put it in the saline, whatever you wanna do. I'm gonna clean the faceplate off. It got bubbly, so I'm gonna do it with the saline. Okay, let's drop those. Peroxide and saline. So you go underneath of the faceplate, and you wanna do it in a rolling motion and get all the way around, of that. Roll around. Oh, that's bubbling. So I'm gonna wipe it off with the saline or water, sterile water. Good. Oh, I got one left. Peroxide it. Roll it around. Get all that clean. Oh, he's bubbly. I'm just gonna get something else. I got these little things too. They're used for whatever. Put that in there. And just wipe away any bubbles. Make sure that it's all clean around the stoma. You wanna look at the stoma, make sure that it's not excoriated or bleeding, that everything's intact. So you have to look underneath of the faceplate. You can tilt the faceplate to look at it and make sure everything looks good and healthy. And then you take your dressing and slide that back underneath of there. You always want to have one that's already pre-cut. Never cut one. If you cut one, it can make loose fibers go down inside of the lungs. That might not be good for Clark. Sorry, buddy.
Like, dang near tore it out, but I don't.
Oh, he's decannulated. Let me get the hemostats. Open him back up. Make sure you always keep an extra trach and hemostat to the bedside in case it does decannulate, and then you can shove them down in there, open it up.
Yes, please.
Okay, and then you've also got this, so you can put that in some water, or if you need to clean up anything, that's good. Okay, but really, Miss Baker's gonna be mad.
It's okay, we won't show her the video.
So really, these things dry off pretty easily. You just want to shake it out. Just make sure there's no bubbles of fluid down inside of there. I only dried it off because I don't want Miss Baker mad at me.
Just blow it out.
You can take these, and if you have a bubble that won't shake out, you can take one of these dry ones and shove it up inside of there. Let's try that end. And oh, look, I got that bubble. Good. Okay. Okay, so then you kind of go a little bit at an angle, like from the CM sideways to it, and then you kind of twist down to put it back in. Line your little guy up and twist it back into place. And that's done. Most places do not have these. We do because we're special. So, usually they have the foam ones that are Velcro. But when you, attach a new trach tie, whether it's these or, the foam ones, tie that in, wrap it around, tie the other side in, and then undo your old one and remove the old one. And then document, and again, make sure that you have an extra trach and hemostats at this bedside. Any questions? Did I do it right?